Hello everyone, I'm Dr. Ankita Jain. Welcome to my channel, Your Dental Tutor, where I share notes in relation to periodontology and dentistry in a very simplified form. And 2 days back, I have uploaded the first part of food impaction, and today I'm going to discuss in continuation of that part only. It's a second part on food impaction. So let's begin. I have already completed in the first part up to the factors causing food impaction. Today I will be discussing sequelae of food impaction, signs and symptoms, prevention and management, prosthesis induced factors for food impaction, and then summary and followed by references. Sequelae of food impaction. So whenever a patient or a person have the food impacted between the teeth, then he will have the urge to dig the material from there. There will be vague pain which radiates deep in the jaws. There would be gingival inflammation because that food particle will irritate the gingiva, which will cause bleeding and foul taste in that particular area. There would be gingival recession because obviously there would be physical trauma to the gingiva which results in recession. Periodontal abscess formation occurs in the advanced cases where food particles are present from a long time and resulting into the bacterial infections resulting in periodontal abscess. There would be varying degree of inflammatory involvement of the PDL and associated elevation of the tooth in the socket. So when there would be periodontal abscess, then that pus or abscess will pop out the tooth in its socket. There would be destruction of the alveolar bone in very advanced cases, and of course the root caries. So these are all the consequences of food impaction. Symptoms which patient will complain, there would be feeling of pressure, vague pain and root caries. So these three symptoms will be presented by the patient of food impaction. Signs which a dentist will see into the patient: bleeding from gingiva and foul taste, recession, periodontitis, abscess formation if present, and alveolar bone loss. So I have quoted a clinical study over here in which they have talked about the various results of food impaction. So if you quote one of the studies in your answers, then it becomes impressive and eye-catching for an examiner. So according to this team, they have concluded that teeth which don't have distal support were found to be most frequent site of food impaction. In 41.6% of cases, they have found this particular factor. Food impaction was found more frequent in the upper tooth rather than in the lower teeth. Alveolar bone loss was not found in the initial stage of food impaction. When there would be continuous food impaction in that particular area for a long period of time, then there would be the periodontal clinical attachment loss and the bone loss. In 18.2% of cases, proximal caries were found at the site of food impaction. Food impaction also affects the patient's occlusion, cusp to marginal relationship, cusp to fossa relationship, and stepped relationship. So due to these reasons, patient occlusion is affected. Now let's see the prevention and treatment. How can we prevent the food impaction? And if it at all occurs, then how should we treat it? First of all, occlusal adjustment. Occlusal adjustment of the plunger cusp mainly. Okay, what is the plunger cusp? We have seen in the previous video that plunger cusp is a cusp that forces or wedges the food into the opposing arch. Round the sharp cusp of the plunger cusp, these plunger cusp are usually the functional cusp of the teeth. So in maxillary arches, it would be the palatal cusp which would act as a plunger cusp in majority of times, and in the mandibular teeth it would be the buccal cusp. But sometimes it can be palatal incline of maxillary buccal cusp and buccal incline of lingual cusp. Now it's very difficult to find the plunger cusp directly into the oral cavity. In order to identify the plunger cusp, we need to examine the study cast. And then when we identify it on the study cast, we can round that particular cusp in the patient's oral cavity. So here it is discussed with the help of this diagram. We can see that there are sharp oblique facets which forces the food particles in the opposite arch. So these sharp cusp act as plunger cusp. So we need to round it as per the dotted lines, and now we can see the changes. These sharp cusp have been converted into the round cusp, and there will be space for the escape of food particle. So that is how occlusal adjustment helps in the prevention of food impaction. Then second is we have to level the occlusal height of marginal ridges. Now marginal ridges are present on the margins or edges of the tooth structure. So when there would be discrepancy between the marginal ridges of adjacent teeth, then also there would be enlarged embrasures and the opposing tooth would be able to wedge the food particles in that particular space. Those marginal ridges can be adjusted with the help of either restoration or by grinding it to a favorable anatomy. Now, we need to restore or grind. It depends upon the relationship of the tooth with opposing tooth structure and to the overall plane of occlusion. So, if the tooth is in contact with the opposing tooth, then slight grinding could be possible. And if it is not, then restoration would increase the height of the tooth. Degree of discrepancy. Now it is associated with the extrusion. Degree of discrepancy is observed in respect to the adjacent teeth. So if there is more extrusion, then there would be more difference between the height of two adjacent teeth. And in that case, restoration with the prosthesis is required on the smaller tooth. And if the extrusion is less, then discrepancy can be managed simply by grinding the elevated tooth. Iatrogenic hazards which are induced by the dentist. So if we grind the tooth, so there is possibility that may land up into the pulp exposure or iatrogenic damages. So it all depends upon the height of the tooth. If it is not treated, then we have to do the restricted grinding. And if the tooth is severely treated, then we should restore the height with the help of restoration. Because grinding in severely treated teeth may result into the pulpal damage. Then we have to consider the slope of marginal ridges. There are external and internal slopes. This is external slope, which helps in establishing the contact point with the adjacent teeth. And this is internal slope, which helps in the escape of the food particles away from the tooth structure. So we have to keep in mind that when we fabricate the restoration, all kind of marginal ridges, cusp should be taken care of. Proper contact point must also be established. And if we recarve the tooth structure or recarve the restoration, then also the location of the contact point and the shape of the cusp should be taken care of. Nivell and team have suggested that if there are tight contacts between the two teeth, like in this case, then we can think of giving food escape grooves on the marginal ridges, this point. So these depressions actually helps in the flushing of food away from the cusp area. Grooves and fossa. Recarve the obliterated or missing fossa. So if the tooth has worn out, if the tooth is treated, then in those cases we usually see that fossas are not present. So we need to recarve them on the tooth structure. These shallow saucer-shaped fossa, mesially and distally with slightly extended grooves, helps in deflecting the food from the inter-proximal side to buccal and lingual side. So that's why these grooves and fossas are very important. Restoring an ideal contact with the adjacent teeth in case of fabrication of crown or in case if we do the restoration of the tooth. So intact, firm proximal contact relationship between the adjacent teeth are important and desirable. These contact points can be established with the help of restoration or orthodontic tooth movement. So sometimes we can see that since birth the spaces are present between the teeth. So in order to prevent food impaction in those spaces, we can go for orthodontic treatment. And also in those cases where spaces have been created in due course of time, there also orthodontic treatment is beneficial, or else restoration can be done always. Ideal contact should be observed in terms of location, width, height and tightness. Contact tightness can be checked with the help of dental floss. Then comes the permanent restoration. So factors which should be considered under permanent restoration are proximal contact, contour of occlusal surfaces, facial and lingual contour. These all points are very important and should be kept in mind. The crown should not be given blindly. These points should be checked because your crown may cause food impaction problem forever and cause further damage to the adjacent teeth also. Prosthesis induced factors causing food impaction. So when we give the prosthesis, certain factors apart from contact points, marginal ridges should be taken care of. So rough surface of the restoration is very prone to plaque accumulation, and that causes interproximal pocket and attachment loss, which further causes the space and where food impaction is quite common. If the margins of restoration is not properly blended with the tooth surface, it gives a space for bacterial accumulation that may cause infection, abscess and etc. and etc. The proximal finish line during the crown preparation should be in line with the interdental papilla. Otherwise, those restorations or crowns will imprint the gingiva, causing the gingival recession or gingival inflammation, thereby creating the papillary space and causing the food impaction. If by any possibility the oral hygiene access is impaired or disturbed due to the excessive pontic to tissue contact, then that may also lead to the plaque accumulation and finally into the food impaction, mainly horizontal food impaction. So by horizontal food impaction, we mean the forces from the cheek and tongue lead to the food impaction. So that's all about the food impaction. Patient always feel an urgency to dig into an affected area. So he will get relief only when that food particle will be removed. But that is not the final treatment of that particular case. That's not the final treatment for that particular case. We have to treat it in such a way that food impaction should not occur in that site. So every factor which is causing food impaction should be considered and should be taken care of. So these are the references. And if you have any queries related to this topic or the periodontal topics, you can email me or give your comments in the comment section. If any topic you want me to take on priority, then you can suggest me through email and commenting in the comment section. And be safe. All the best for exams. Thank you.